Okay. Are we back to where we need to be? Yeah. Okay. Alrighty. So yeah, with your iron fortified cereals, they're the ones that have better nutritionally dense, I guess, kinds of foods. And Frosted Mini Wheats and Kix were some of my kids' favorites because when I was in school and I had little kids, we had WIC and it was pretty awesome. It was a lot of help. And then egg yolks, dried beans. I don't know about you guys, but my last one had a texture thing with beans, and I have a texture thing with beans. Unless they're green, I really don't like them. And so we didn't have a lot of beans, but one time I went to one of the WIC classes, and they made fudge. Like, seriously made fudge with pinto beans in it. And it didn't have a weird texture. For the longest time, I would make fudge for my kids so that they would eat, so I could use the beans that I was getting on my WIC checks. All right, and then fruits like peaches and raisins, anything that's like dried fruits are really quite good. And then baked potatoes, organ meats, poultry, fish. So lots of chicken. So you can see, not necessarily chicken nuggets, you know, they're a little bit more processed. But if they can cook a chicken breast and chunk it up or something like that and give it to them with a few of these other things. A lot of them will need to be on iron supplements. Especially if they're drinking an iron fortified formula, then that's okay. But if they are just drinking milk or they're young enough that they, sometimes parents wean them off of formula preemptively, I guess, because it's pretty expensive. And that's another way where WIC can kind of bridge that gap. But they should be on like these little iron drops. And they don't taste terrible. Most kids take them pretty good, and it's just a little dropper. Just make sure that they know it can cause constipation and kind of the black stools. They're not necessarily tarry, but they're a little sticky and they're kind of dark, and parents get a little nervous about that. So make sure you tell them. And it shouldn't be given with meals, which is a dichotomy because it can upset their stomach. And so it should be given about 30 minutes before meals so you can start to get good absorption. But it won't be in there long enough to upset their stomach. I used to tell parents too, if they were taking iron drops, to give them just a little bit of juice in the day, each day, that little bit of sugar and fruit and stuff like that, or to give them some dried fruits that'll help kind of keep them from being too constipated. All right, so hemophilia. So I noticed in the presentation that's on bleeding, prevention of bleeding, that they talk a little bit about what hemophilia is also. So instead of stealing their thunder, I'll just reiterate what they said. So I'm trying to remember who has my bleeding prevention one. Taylor.
Okay.
All right, Miss Taylor, let's see here. Let's go here. All right, I will click through your slides for me. You just tell me, or for you, just tell me when you are ready to go.
Okay. So my presentation
for your attention, you guys.
Okay, so my presentation is on prevention of bleeding in hemophilia patients. So you can go to the next slide. So what is hemophilia? Hemophilia is a group of hereditary bleeding disorders that result from a severe lack of specific clotting factors. The two most common are hemophilia A, which is classic hemophilia, and hemophilia B, which is Christmas disease. Hemophilia A accounts for 80% of all types of hemophilia and results from a deficiency of factor VIII. Hemophilia B is a factor IX deficiency, and approximately 15% of people with hemophilia have this type. Next slide. Okay, so hemophilia A and B are inherited as X-linked recessive traits. This means that females who receive the gene will be carriers, and males who receive the gene are born with hemophilia. Therefore, males are predominantly affected by this disease. Although it is possible for females to be affected by hemophilia, it is very rare. So for a female to be affected, she would have to have an affected father, and a carrier mother to inherit both of the affected X genes. Next slide. Okay, so signs and symptoms. They're going to bleed into the joints, causing swelling and pain or tightness. So they'll have decreased range of motion, which often affects the knees, elbows, and ankles. They'll have bruising or bleeding into the muscle and soft tissue, causing a buildup of blood in the area, also known as a hematoma. They'll have bleeding of the mouth and gums, bleeding that is hard to stop after losing a tooth, bleeding after circumcision, bleeding after having shots like vaccinations, bleeding in the head of an infant after a difficult delivery, blood in the urine or stool, and frequent and hard to stop nosebleeds. So basically, they will bleed very easily, and when they do, it's harder to stop. Next slide. So there's mild versus severe. In mild hemophilia, excessive bleeding is usually associated with surgery or significant trauma. However, once they begin to bleed, it can be just as serious as a person with a severe form of the disease. And in severe hemophilia, spontaneous bleeding can occur in the joints and brain without any precipitated trauma. Major trauma can cause bleeding that's so severe it becomes life-threatening. Next slide. Okay, so diagnostic testing. So in mild hemophilia, a surgical procedure or trauma is the first time a bleeding problem is noticed because it's so hard for them to control the bleeding. And a prolonged partial thromboplastin time blood test is a test to see how long it takes for your blood to clot. And patients with hemophilia have a prolonged PTT test. And that picture to the side is what a PTT blood test tube looks like. When you fill it up, you have to fill it exactly to the top of the white label and be sure not to go over it or under it. And there's also a little dented line on the other side of the white label that you can measure it to. The lab is super picky with this test, so you have to make sure you fill it exactly to the mark or they'll reject it. And then testing various clotting factor levels determine which one is missing. Next slide. Okay, so therapeutic measures. Hemophilia is not curable but can be treated. Treatment is aimed at preventing deformities and increasing life expectancy. Mild hemophilia can be treated with an injection or inhalation of desmopressin. Severe hemophilia A is treated with factor 8 and hemophilia B is treated with factor 9. So it's basically they are treated with the clotting factor that they're missing. And both are given intravenously. Blood transfusions are uncommon now because of these treatments, but may be necessary after severe trauma or surgery. And then, like I said, just infusing the missing clotting factors to stop the bleeding is the best way to treat this disease. And people with hemophilia can learn how to perform these infusions themselves so that they can stop the bleeding episodes and prevent more bleeding episodes in the future. The next slide. Complications may occur when therapy is started too late. Minor traumas typically need to be treated with at least 72 hours of added clotting factors, and major traumas and surgeries may require up to 14 days of clotting factors to prevent sudden bleeding. And then with severe patients, you want to treat them prophylactically to prevent bleeding. Next slide. So nursing implications, you want to monitor the hemoglobin and hematocrit levels carefully during acute bleeding episodes. Apply ice or pressure on bleeding sites to help slow the bleeding because it'll vasoconstrict. Monitor factor 8 or 9 levels to determine if it's adequate. Monitor vital signs for falling blood pressure and rising pulse rate. And this can be a sign of hypovolemic shock. Assess all body systems for bleeding and perform a thorough pain assessment. Next slide. So you want to listen to your patients. Be careful, pay careful attention to patients who say that they are bleeding, even if there are no outward signs, because they know their bodies and they know if they're bleeding. Evaluate and educate the patient and family about the disease process and how to prevent bleeding episodes. And instruct patients to use preventative care before going to the dentist and when to seek emergency care. Next slide. Okay, so for my learning activity, pull out a sheet of paper and draw a huge blood drop on your paper that looks like this. And then on the next slide, any bolded terms or underlined, you can either write or draw in your blood drop to help you remember the preventative measures. So just let me know when you guys are ready.
So tell me again what you want them to draw.
Just like a big blood drop on their paper, just like this.
Okay. And what are they supposed to write in it?
So that'll be on the next slide. I just wanted everybody to like have it ready.
Okay.
And then, so any bolded or underlined terms, you can either write or like draw a picture to help you remember.
Inside of,
like the blood drop.
Slide?
What'd you say?
Do you want me to go to the next slide?
Yeah, if you guys are ready.
Okay. I didn't want to give it away if you didn't want me to.
Okay, so yeah, so like I said, any bolded and underlined terms, you can either write it in your blood drop or draw a picture to help you remember. So preventative measures, you're going to use an electrical razor for shaving. You want to use a soft toothbrush and avoid flossing because it's easy for them to bleed in the mouth and gums, so they have to be gentle. You want to avoid invasive procedures such as enemas, douches, suppositories, and rectal temperatures. Avoid IM injections. And then when checking a blood pressure, inflate the cuff until the pulse is obliterated, because if you inflate it too much, you can cause bruising. Avoid drugs like NSAIDs and aspirin that increase risk of bleeding. You'll want to avoid blood draws whenever possible. Maintain pressure on puncture sites for 5 minutes. And that's a pretty long time when you think about it. So try and come up with things to talk to them about instead of just like staring them in the eyes. Encourage use of shoes and slippers when out of bed, so if they step on something, it protects their feet from injury. Move and turn patient gently to avoid bruising. Instruct the patient to blow nose gently. Keep area clutter-free to prevent bumps, bruises, and falls. Administer stool softeners as ordered to prevent straining. And advise the patient to consult with healthcare provider about whether sexual intercourse is safe. And then the last slide is just my references, so you guys can take as long as you need on this slide.
And I've got this posted on Canvas too, so that you guys can do that. But that was very inclusive. I thought that was very good because sometimes there are things that people miss. I think everything that I had on my list, other than wearing an ID band, wearing a medical bracelet, is a good idea. But other than that, you hit everything that I have on here.
Awesome.
So way to go. Good job. Give her a hand. Okay. That was a good activity. All right. Sounds like Brian Regan. Does anybody know that, where he's like, is this a good activity?
My favorite one is like, my knee hurts.
My knee hurts what?
He's talking about getting older.
Oh.
I wake up in the morning and my knee hurts. I guess forever.
I guess forever.
Like,
all right.
The doctor told me my knee hurts.
So we don't have to go through a bunch of these because she really touched on it very, very well. Just remember that the clotting protein is called a factor and that it isn't a platelet problem. Okay, that's when she was referring to factor 8 and factor 9. They're proteins. They bleed longer, like she said, not necessarily faster. It's not contagious and it has treatment, but there's no cure. And then we did her presentation. She talked about hemophilia A, being the classic hemophilia being the factor 8 deficiency, and it is the most severe. When she talked about bleeding into the joints, that spontaneous bleeding into the joints, like she mentioned, you will see that most of the time with hemophilia A. It can happen a little bit in B, and here's just some pictures where it can just happen. Like they literally could just be standing here and start bleeding into their knee or into their elbow, and it's really, really painful. And then the Christmas disease, like she said, is the factor 9. These are the two most common. And so the other one that is a small percentage and falls a lot into the same interventions that she said, same therapeutic measures, is this von Willebrand disease. Von Willebrand factor is the factor that's missing. So it's not 8 and it's not 9, it's von Willebrand factor. And it's a platelet adhesion aggregation kind of issue. So you want those platelets to be able to come to the site and be sticky enough to stay at the site. Does that make sense? It affects both genders more equally, and you have mucocutaneous bleeding. So wherever mucous membranes are transitioning to skin, you can have issues with bleeding. So like right here in their gums, you can have it in the eyes, you can have it the anal area, you can have it after intercourse because of the shearing sometimes in the vagina. And so they have to be really careful, like she said, to talk to their healthcare provider and make sure that sexual intercourse is okay. They have problems with nosebleeds, abnormally heavy menstrual periods, and then GI and GU bleeding. Like she said, sometimes they have to monitor urine and stool output just to be sure that they're not bleeding. And then they can have issues with hemorrhage after childbirth and even just dental extractions and postoperative. Oh, yeah, that's a bad deal. They need to, Taylor said sometimes if it's not like the mild and the severe, with the mild, they might need prophylactic treatment for a couple of days, as opposed to the severe needing prophylactic treatment sometimes for weeks. So right before they deliver, then they would have them start taking their factor daily if they have a more severe form. Just a couple little things here. They can become easily injured. So sometimes if they're not circumcised and somebody didn't pick up on the fact that their heel stick was bleeding a little bit longer than it should, and maybe to have them tested at that point, then they may not know that the child has an issue until they start to pull themselves up to stand, or they're crawling and all of a sudden their knee swells up and they get this big hematoma, or they have bleeding into the joint. So then they go in. So make sure you're asking really good history questions. If you have somebody come into the clinic where you're working and they have a baby that has just one knee that's very swollen, red, hot, or it's looking bruised, and be an advocate for getting some good blood work done for them. The bleeding into the joint that she talked about, so like that poor little knee down there, is called hemarthrosis. Oh, I know, doesn't that look terrible? The primary site is in the synovium, and it can cause a tingling sensation, and it's warm. It's followed by increased pain. When you have chronic problems with bleeding into the joint, you have what they call synovitis, and that can cause permanent damage to the joint, range of motion, decreased range of motion, and sometimes later in life they end up having to have a joint replacement because of all of the damage of bleeding into that joint. And once it has bled into that joint a couple of times, it is weaker and it's more likely to bleed into that same joint. Muscle is the second most frequent site, and like Taylor said, you can get hematoma where it bleeds into that soft tissue and into the muscle, and then the mouth, GI, GU, kind of like that. That's primary, secondary, and it kind of goes down. She mentioned that the PTT is the one that's prolonged. Has anybody worked in phlebotomy that might know why the PT isn't? Your PT measures factors like 1, 2, 5, 7, and 10. I think that's it, 1, 2, 5, 7, 10. So the factor's not affected. So they don't, yeah. So the factor's not affected. But the PTT measures 8 and 9, and that's where it'll be prolonged. So she was dead on with that. Deficiencies are in the intrinsic pathway. So extrinsic, you have your fibrinogen, and you have other factors that are tissue related in that clotting cascade. And we'll look at a picture here. She also mentioned that there are other tests that you can do for the mild and the severe, mild and more severe. And that's where they look at factor assays. If they're low or absent. So if they just don't have very much factor, or if they have no factor. And they will look at that here. And then the type and severity, whether it's 8 or whether it's 9, whether it's von Willebrand. whether it's mild or severe. They'll be able to tell from some of these other tests. So here's just a little picture of your clotting cascade, and you can see A and B fall right here in the P2T line. And over here you've got 7 for the PT, and it comes right down to 10, 5, 2, and 1. And you've got your thrombin and your fibrin. These are more what they call extrinsic or tissue-related pieces of the clotting cascade, where these are more some of your factors, and so that are in the blood. So you've got 8 and 9 here, and that's why you'll have it on that side. She talked about vasopressin. I think she did, didn't she? I think she did. But she did talk about replacing clotting factors. And so that is often what they'll do, and they like them to be, when they measure their levels, that they have greater than 1% of that factor. That shows that they've got good clotting ability, I guess, is they've got greater than 1% of that factor. So you can imagine how low that can go if that's what we're kind of shooting for with our factors, right? Blood and plasma, like she said, isn't very common anymore. What are some of our risks with blood and plasma? What's that?
Hepatitis?
Yeah, hepatitis B. Yep, so we still, even though we have great screening process, it's still blood products, right? And if they have had several, then they are more likely to have a transfusion reaction. So they usually have to have them be washed, so that they wash some more of the white cells out of there. And if they've had a lot of transfusions, sometimes, especially in cancer patients, they have to irradiate the blood to make sure that they aren't having the transfusion reactions that they can't fight off. Desmopressin, or DDAVP, is a synthetic vasopressor. And what it does is it increases plasma factors of 8 and von Willebrand factors. The nice thing about this is it's synthetic. So no blood products. So it works really, really well. And then they can give them antifibrinolytics. Amicar is a pretty common one, but you don't have to know the name for me. Just know, oh my heck, somebody's heavy footed up there. That it's for mucous membrane bleeding. So they will give that, when you have your fibrinolytics, it's breaking down your fibrin. We don't want it to do that. So that's the antifibrinolytics. Tonsillectomies and dental extractions, so they will give those. Sometimes you can't wait for a dental extraction. If they have an abscess tooth, or something, maybe it's broken off from an accident or a trauma, and we need to get it out of there, then they can give them this. They can give them some DDAVP, and give them some clotting factor so that they can get that out of there sooner rather than later. And then it can be used alone or in conjunction with their factors and with their DDAVP. And you know what a cool side note or a side effect of DDAVP is? Decreased urine output. And so for a while, they went through like phases. I don't know if they do it as much anymore, but they would give it to kids who were older that were still having problems wetting the bed. And so before they'd go to bed, they'd have a small dose of DDAVP, and then it would help them decrease urine output and have some success with making it through the night. So I don't know if they still do it. I don't have kids that young anymore.
Walgreens?
What's that?
Can I buy this at Walgreens?
Yeah. Talk to your physician. I don't know. My kids are, my youngest is 15, so I don't know. But I know that my oldest two had trouble with that when I went through my divorce. And they were 8 and 11 and started wetting the bed a little bit. And were feeling really sad because, because they're older. And it was just kind of traumatic. And so it gave them some success, gave them some successful nights. And just for a couple of months, I think it was probably 2, maybe 3 months. And they were kind of back on track. But then they didn't have to feel so bad, I guess. It kind of helped them out. So that was a long time ago. He's like they're 25 and 28 now. So I don't know if they still do it. All right, RICE is a good acronym for when these kids start bleeding into the joint or they have an injury or something. Rest, ice, compression, and elevation. You don't want them to be walking on that leg right, that has that little knee that's just so swollen, has a lot of blood in the joint, sometimes they can't. Sometimes they're completely immobile with that. Ice it, compress it. So put a snug ACE wrap around it, like not tight. Obviously, you want your CMS check to be okay, but good and snug. And then elevate it. Get it up on a pillow. That's a pretty quick, easy thing to do, right? Super fast. Just slide a pillow under there, a couple of pillows, and elevate it. And then evaluate the need for muscle strengthening for the affected joint after the bleed is resolved. I should have underlined that. And often they will involve PT. But the PT is after the bleed has resolved because right now we want to rest it. Idiopathic thrombocytopenic purpura. Say that 5 times fast. ITP is much easier. Now this is a platelet deficiency. Okay. So Taylor talked about factor deficiency. That's a protein that helps clotting. Has nothing to do with platelets. Now we're talking platelets. Acute bruising and generalized rash and petechial hemorrhages. So you can see down here, or maybe my laptop might be in the way, but you can see all the little petechial spots there. And they have some bleeding in those little capillaries. They don't have enough platelets to be able to hold or to be able to not bleed out of those little vessels into the tissue. They're preceded by a viral infection. So 50% of these diagnoses, they've had a viral infection and now they're having platelet issues. So that being said, they're actually self-limiting. Did I say that here? Oh yeah, it disappears in a few weeks. So they can have a lot of trouble for a short period of time, or it can be a little bit longer, but sometimes it's very self-limiting. The platelet count can be less than 20,000. Yeah.
So last week when I was at clinical, I had a patient that I think had this, and his platelet level was like I think it was like at 6.
Wow.
Or like, and then when he came into the ER, I think he was like at a 2.
Holy smokes. Yeah, is he undergoing chemotherapy or anything?
Well, they said he had a recent dental procedure done, and he kept on bleeding, and then like he never really came to the ER. And then we were gonna do a liver biopsy on him because I think he has cancer also, or he might have cancer.
Yeah.
And so they had to wait till his platelets were up to like 50.
Oh yeah, because your liver's very vascular.
Yeah, to even like do the biopsy on him.
Yeah. Did they transfuse platelets?
Yeah, so before I got there, he was there for like 2 days already. So he had like 2 blood transfusions.
Okay. Yeah. So where they transfuse platelets. So yeah, they wanted to make sure it was greater than 50,000. Is that what you're saying? Yeah, before they did a liver biopsy for sure. So the white blood cell count will be normal and the platelets are low. Sometimes if that white blood cell count is super high and the platelets are super low, we're going to talk about cancer here in a little bit. That's kind of an indicator maybe of ALL. The body's kicking out all these white blood cells, so much so that it limits the platelets and the red blood cells and stuff like that. So that could be an issue if you start to see that change in the white blood cells and the platelets. But for now, they've had the viral infection, and now the body is attacking the platelets. That's what's happening. So they can give, for treatment, they can give them corticosteroids. Corticosteroids are great for inflammation, but what else do? They do make you more susceptible to infection because they limit your immune response. Okay, so that's why you have more susceptibility to infection, because they will end up limiting your immune response. And so then the body can't as easily attack the platelets. And they can also give IVIG, and IVIG helps make antibodies, which seems almost counterintuitive. But what it does is it overwhelms the spleen. And the spleen is used largely with immunity, right? And so now it's got so much that's going on that it basically can't multitask as well. And it won't be attacking these platelets as aggressively. Pretty crazy sometimes the things that they figure out. Winrow just is a synthetic that helps make platelets. And then, and then they can give platelets. So I have that kind of at the bottom because unless they're super low and needing a procedure or something like that, I try to steer clear of blood products when they can. Okay, so we did the respiratory bleeding one. This teaching, she had all that on there. Yeah, soft toothbrush, all of those kinds of things. Oh, and the protect, but don't overprotect is one that I would see with parents a lot. They didn't want them to ride bikes, and they didn't want them to rollerblade, and they didn't want them to do any of these things. And we would have to encourage them, let them ride a bike, but put a helmet on them. Even put little knee pads and elbow pads. That way, if they fall off, those joints are protected. Obviously, don't let them play lacrosse. Don't let them play football. But being on the swim team is really great. Sometimes if they some parents would let them play volleyball. That wasn't something that was really encouraged by a lot of physicians because how many times do they hit their knees or fall down on their elbows and stuff? And so some of their, some sports that are not, they're called non-contact sports, aren't always non-contact sports. But swimming is a really good one that we would encourage them to do, just so that they can get out and be strong and be healthy and be a part of something. You know, kids in sports really have that camaraderie. And sometimes if people are so worried about them bleeding with any little bump, and sometimes they want to put them in a bubble. Okay, so we're at a good spot for a break.
Double boy.
What?
A double boy.
Oh, is that a thing?
Movie.
Oh, is it?
Yeah.
Oh, I don't get out much. Several semesters ago, someone knew this little girl. It was her niece's friend, or her niece, something like that. She's like, I know her. She was at primaries. I was like, oh, well, I hope it's good that I have her picture. It was on the internet. So I'm thinking that it's okay that they have it up there. All right, so go ahead and take a 10-minute break. What is that? Come back at a quarter after, and we'll talk about cancer. We're going to try and play a game if you guys promise not to kill each other with it.
Yeah.
No promises. Okay. Oh, beautiful. Did you get it all worked out?
Yeah, Renee just said after you signed it, she would set it up so I could do it at home.
Oh, yeah. I meant your car and stuff.
Oh.
Yeah.
It's luckily it's brand new. It's under warranty.
Oh,
so
you're like, what the heck?
Like, I know. We drove it down.
Today's the
to church
20th?
to see my brother, and it was brand new. And then luckily
Oh.
my parents were there too, behind us.
Oh,
Like,
that's
we weren't
good.
stranded alone.
Oh, that's good.
So it just sucked all.
That St. George trip, I have had my boys, I have one that lives in Vegas,
Oh yeah.
and my boys have had more problems on the stretch between St. George and here, generally in Beaver at midnight,
Yeah.
because they love to leave late and drive
Right.
through the night because
Yeah.
there's less cops. I don't know. Anyway, I pretend not to. I just like get home safe. But they've had cars break down. They've had new cars. I'm like, what the heck?
We were like 20 minutes from Cedar City. We left early Sunday morning. I was like, we'll get home.
Oh, yeah.
All day Sunday to do everything. We rolled in Sunday at like 3 a.m.
Oh
I
my
was
god.
like, yeah, I'm not taking my
Oh.
I was like, there's no way.
Yeah, I've got to tow my car.
Yes, exactly.
You're welcome.
Yeah.
Okay. I'm gonna move this somewhere where I won't trip on it and it's out of the way.
Resale value like 600. There's like videos coming out like every freaking stuff.
There's not a lot of room in here. Usually I pull the tables like out, like so we have a whole middle. No. Okay. Okay. Who said I'm just talking to myself? You know, when I'm talking to myself and my husband says, what? Which is rare, that he'll listen. I'll say, I'm just talking to myself. And he's like, why do you do that? I said, because I listen the best. I listen better than anybody else I know. Oh, yeah. That Billy Idol song? I don't remember who sings it.
Yeah, that is really
Oh, yeah, we're gonna Smith for a hot minute. Like, you should remember all the songs, basically. Oh, like over the top? Yeah. Oh, how funny. I was thinking you just dated yourself. Logan will show me songs and he's like, listen to this song. I'm like, that is a good song. He's like, I know, right? I'm like, and it's a remake of that good old 80s music. He's like, what? No, it's not. Uh-huh, it is. Or he'll say, yeah.
in the 80s. I'm like, oh wow, okay.
The 80s was a good music era, I think. I mean, that I was a teenager in the 80s. So your teenage years, you listen to lots of music and stuff. So.
But we're in the early 90s, so.
Well, I'm probably old enough to be your mom.
I don't know. I'm almost like 58, so.
Well, I'm not, but I do have a son who's 28, 25, 22, and 15.
That's right. We were talking about this.
Yeah.
I could be your daughter also.
Yeah. Yeah. And then I have a daughter-in-law since May, so she's super cute. I know, she's like this big. She's from Peru.
Oh my gosh.
And our family pictures, like at the wedding, is like the Johnsons. My husband's 6'4". And then Eric and Angela, and then all these little Peruvian family members. It looks so funny. It's hilarious when you look at the picture.
So is that your kid's stepdad then?
Yeah, my 3 big boys are from my first marriage.
That's right. I remember you talking about when we first started class.
Yeah, and then Logan is Tyler's. So.
My friend is married to a Peruvian, and she always
It's like you
has
can't see
a
the line.
Yeah.
You're like, bro, I'm
motorcycle.
the right way.
She's always like, don't go by that motorcycle, you're gonna get a cold. And then my other friend is Peruvian, and she's like, that's a very like cultural.
What is very cultural?
Just like she has this saying, like she won't let him ride his motorcycle because he's gonna catch a cold.
Oh, yeah, she says really cute things. She speaks very good English, but her tenses, like she'll text me, I had going. You know what I mean? Like sometimes they don't, instead of I am going or I went or something like that, I am went, or every once in a while she's got it a little bit goofy. Yeah. And it's so super cute. And her, Eric sent me a video of her trying to voice remote the TV. Oh my gosh. It's hysterical. She's like, Modern Family. And it's like, Mother Family. And she's like, no. She's like, Modern Family. And it's like, it says something else. And she's like, stop taping me.
That's so funny.
That's like
She's so cute.
my friend is from Colombia, and she does the same thing when she texts me. She says, I like the same thing. Like, she'll call me Kaylee because like her she can't really say Kylie very well. Yeah. So it's like Kaylee. I know no.
I know no. Yeah.
What are you talking about? Like.
Yeah. They came here. Well, they went up through the salt flats. She wanted to see the salt flats, and they did a bunch of really cool pictures out there. And then they went up through Idaho and saw my family up in Idaho, and then came down and stayed with us right around the time of our birthdays. Hers and this is September 7th and September 22nd. So we had like a big family barbecue with my husband's family, because they didn't all go to the wedding because all the COVID stuff in May. It was just really small. And so they got to meet her. So I made her Trace Leche's cake. Holy crap, that's time intensive. Because I made it from scratch. Apparently there's a mix you can make. I don't know. But I made it from scratch. But it was so good.
Yeah.
It was way good. I loved it. I was like, I may never make it again for you. I love you. But
So this friend, I made her empanadas.
oh yeah.
I made her like Colombian empanadas. When her mom was staying with her, I made them from scratch, and I brought them over. And her mom, I was all in Spanish. I didn't understand most of it. What was happening? But she like translated. She says, "Now you can get married because you can cook and clean for your husband."
Oh, I love it. Yeah, in Bolivia they call those empanadas salteñas. Salteñas with a T, almost like saltine crackers. So like salteñas, and they're full of like meat and rice and stuff like that. It's really interesting spices in the meat.
Yeah.
But I have a son who served a mission in Bolivia, and before he left, like I was in the mood to find all these Bolivian foods. And it's really time intensive to make those empanadas and salteñas and stuff. And taco.
Who's making salteñas?
I made salteñas.
Are you gonna bring it? I love
Well, no. I made them. He's 25 now, and when I initially he was 18. So I did them 7 years ago.
When I was in Bolivia, I ate like 10 a day, I swear.
Yeah.
Amazing.
He's like, Mom, those were pretty good. They weren't like as authentic as they were in Bolivia. I was like, well, duh, I'm an Idaho girl.
Where was he?
Several places. He went to a little village called Teresa, and he went to, oh my gosh, I can't think of all the places now.
My husband served in Bolivia.
Uh-huh.
And then we went back for like 3 weeks.
Oh, did you? Yeah, he wants to go back. He'll graduate with his bachelor's in December. And then he wants to work for like 3 months and save all his money and go back and live in Bolivia for like 6 months. Uh-huh. Yeah, it's pretty cool. Okay. Alrighty, here we go. Let's see. I'll probably have fun. Uh-oh. What the heck? See, Mark, look at the things you taught me. Look at the things, all the things I've learned. Okay, so now I go back to here, the current slide. Hey! See, I'm not too bad. I'm kind of a quick study. Okay, can you see on Blue Button? Can you see this back up here now? Okay, yeah, we're good. Okay, let's talk leukemia. It's kind of sad. This is kind of a sad part of the lecture, but it's okay because now you guys will have skills to kind of be able to work with these little guys. It's a cancer found in the blood and bone marrow. It's caused by an uncontrolled reproduction of white blood cells. Because the bone marrow is kicking out all these white blood cells, there's a decreased production of red blood cells, platelets, and normal white blood cells. So you will see all of these immature blast cells, all these immature white cells, and the reason they call it like white blood disease in some places because it actually looks almost milky. There's so many white blood cells in it. So there's 4 different types, and the 2 that we're going to focus on are the acute. So if you hear somebody that has chronic lymphoblastic leukemia, or sometimes it'll say lymphocytic, either way, and same here, the lymphoblastic or lymphocytic leukemia. The chronic grows slower, and often people will just take an oral chemotherapeutic agent just to keep it at bay, and many people will end up dying of other things before they end up dying of the chronic forms. But the acute forms need immediate and pretty swift and severe treatment. So your mature leukocytes, so you have your monocytes that defend the body against infection, and your granulocytes, so you guys kind of know the split out of these. Eosinophils and basophils you will often see higher in what? Do you know? And basophils, allergic reactions, yeah. Anaphylaxis, and then neutrophils, you'll see higher usually with what kind of infections? A lot.
What are the first response?
Oh, bacterial?
Bacterial, yes. More so, you will see them be a little bit higher with bacterial. And lymphocytes more with viral. Your T cells and your B cells, your T cells are like your attackers. And your B cells, what's that?
Oh, I was like the T cells, A.
Oh yeah. So these are your attackers. They'll hit first, like when a virus, if somebody's coming down with a virus, you'll see those be really high. And then your B cells help with your immunity also by helping with antibodies. So with ALL, you have an uncontrolled reproduction of deformed lymphocytes. You will often hear them say they have B cell leukemia or they have T cell leukemia, and that helps differentiate the treatment a little bit. It's the most common childhood cancer. About 70 to 75% of childhood leukemias. So the others are the AML, and we'll talk about those in a minute. It often occurs between 2 and 5 years of age and most commonly seen in Caucasian and Hispanic kids. It's often seen in kids with trisomy 21, those poor little guys. They're more likely to have heart defects, more likely to get ALL, and more likely to have diabetes. So that they're already struggling with their little genetics there, and then they have all of these other issues. 90% of these kids have a long-term survival. It's a very good survival rate, but it is a lot of treatment, and it's pretty severe. And then for some reason, there's a higher incidence in boys. With AML, acute myelogenous leukemia, or myeloid, you'll hear it like that, 20 to 25% of the childhood leukemias, and it involves the myeloid cells. It's more common in the Hispanic population. And usually by the time they're a year old is when it really peaks, is when most of those diagnoses happen. And the cure rate is only about 40%. So it's quite a bit lower, and it's pretty swift, severe treatment too, same as ALL. Okay, so clinical manifestations. Let me back up one sec. I can't remember if I don't think I'm stealing the thunder of my next presentation. It's okay?
Yeah.
Okay. I was like, wait a minute. I hate to do that to you guys. I'd rather just reiterate at the end instead of telling it all and then having you go, well, it's all been said. All right. So clinical manifestations. If you have all these white cells and you're not having enough platelets and enough red blood cells, hey. Yes.
Leslie, when she was younger, diagnosed herself with leukemia.
Thank you.
Oh. So Leslie self-diagnosis of leukemia.
Let me explain.
Okay.
I was so tired all the time, and I kept finding bruises, and I didn't know where they came from. And when I Googled it, that's what came up.
Oh, there you go. You will find those on here. She was very, very tired, so we'll reiterate for those online that missed that wonderful diagnosis. She was very tired all the time and kept finding these random bruises, which are some of the things that fall on here. And you will find in a little video we watched that is very common. So there you go. Google knows all. Maybe she had leukemia and self-cured. All right. So the anemia, it can be very fatigued and very pale. The thrombocytopenia can cause petechiae, bruising, gingival and cutaneous or nasal bleeding. There we go. We've got two for two there. 2 for 2 categories. Neutropenia, they run fevers and they're usually unexplained. So they're not usually linked with a virus or bacteria, any kind of infection. They just run these random fevers. And then they'll have frequent infections because these white blood cells that are being kicked out are immature. They're not able to fight off infections. So there's a lot of them, but they're actually, because there's so many of them, they don't have enough, the bone marrow isn't kicking out enough of the mature white blood cells that can fight infections. Hepatosplenomegaly, so you've got all these white blood cells that are trying to be processed through the spleen and the liver, and so sometimes those can be enlarged. Bone and joint pain, lymphadenopathy, so they'll have swollen lymph nodes. Central nervous system, they can have intracranial hemorrhages. Usually just small. I have seen a couple that were a little bit bigger and resulted in some stroke-like symptoms, but usually small. And it's because they don't have enough platelets, right, to keep those bleeds from happening. And so they can end up with the intracranial hemorrhages, lots of headaches. And then they can have abdominal pain, vomiting, and the unexplained weight loss. This is a hallmark of cancer, not just ALL. And sometimes, and this is my plug for a really good history, no matter what area you work in, do a really good, complete, and thorough history. For 6 months, my husband was sick and had these random different things that were happening, and we will find this in this video too that we watched, and nobody was making the connections. And you go to one kind of doctor, like he was having this profound itching, and so we went to a dermatologist who just treated the itching, and it didn't treat it, and we found later that it was very diagnostic of Hodgkin's lymphoma. But we didn't think to say to a dermatologist, hey, he's losing weight. You know what I mean? And he never asked. And hey, he runs kind of these random fevers, but you're a skin doctor, so we're not thinking to say these things. He's really achy all the time. But he would go to his regular doctor, and he didn't want to be a complainer, and so he really wouldn't say too much. And so they would ask, and just right before, I think 6 months before that, he was diagnosed with diabetes, type 2 diabetes, and so they had said your weight will fluctuate. So as he started losing weight, I was like, you are losing too much weight. And he's like, they said that I would probably lose weight once I went on metformin and stuff. I'm like, no, I'm pretty sure this is not right. And then when he had dropped 30 pounds in 5 months, I was like, okay, wait, we have a problem. Like, we really have a problem. It's like, no, this is, and it was summertime and it was hot and he works outside. And so we kind of just kept writing it off. Would go to see different doctors and nobody would ever do a real complete history. And finally, when we went, he started having chest pain. And so then I started getting like really, really nervous. And he would kind of be like, oh, it hurts. I think it might just be in the muscle, you know? And so then when they called me and he's like, I'm having a lot of chest pain. I'm going to the Instacare. This is a man that has to be half dead to go to see the doctor. So the fact that he's going to the Instacare really had me nervous. They did a 5-lead ECG. I don't know why they didn't do a 12-lead. They did a 5-lead and told him he was fine. They palpated and was like, yeah, it's a little bit swollen. You're probably right. It's probably just some muscle stuff. And so, just kind of massage it, work it out. Because he drives 18-wheelers and throws straps. I don't know if any of you guys know what that means, but he throws those straps clear up over the top. And then we'll go lock him down on the other side. And he throws with that left arm. And so he thought maybe it was just too much there. But again, they didn't ask him many things that were going on. Didn't ask him about weight loss. Didn't ask him about joint pain, abdominal pain, nausea and vomiting. Didn't ask him anything. Just, oh, you came in with chest pain? Let's slap you with a 5-lead ECG. Looks just fine. Probably muscle pain. And sent him out the door with some ibuprofen 800s. And so when he got home, I was like, You only did it 5 leads. He's like, why are you yelling at me? I'm like, I can't believe this. I'm not yelling at you. I'm just yelling. And so anyway, within 3 days, he was in the ER with chest pain. And I was at work at night, and the fact that he went to the ER and at night had me beside myself. And I was working in Bergen City and had to make it to McKay while they were working him up. He had pericarditis, and it was because he had a softball-sized mass in his chest. He had been short of breath for several months, but it was pushing on his lung. And when they did a lung function test, he only had like 30% of his lung volume in that side, and it showed on his scan that it just has this little bit of lung down here and this mass in his chest. Well, then they started asking questions. Well, have you had any weight loss? At that point, he had almost 50 pounds of weight loss. He's 6'4", so he looked like a skeleton. And had joint pain, nausea, but with metformin, it can be a little bit nauseous. But you start to put all of these together, and then you start to go, I think there's a bigger problem than just a new diagnosis of diabetes or a new medication or something like that. So that's kind of my plug for a really good history and really putting all those pieces together. Okay. Oh, this little video. Let's see here. No? Where is it? There it is. All right, can you see on there what I'm seeing here?
Yes.
Okay. Oh, my volume's all the way up. There we go. I know he talks so soft, my volume's all the way up. Maybe you should type to them just to read. Like some titles. That's a red flag in one place. What? Not the smartest person, but I'm thinking no. And then there's just all those same little things that appeared. But a reaction to the sunscreen? Really? Where's my? It's not going back. If I hit escape, it's not going out. It's not going away. Mark. Shouldn't it just go back down?
It's just this on regular YouTube.
Yeah.
It's just this.
Okay. I don't know, I must have unshared as we were doing all of the everything, and then I closed. When it clicked, I think I closed it all the way up. I know. It's It's a lot. It's frustrating. Okay, now do they see? Yeah, okay. All right. So for your diagnosis, they'll do blood tests first. Look at the CBC with differentials, and the differentials are on the white blood cell count. They'll do a lumbar puncture or spinal tap. To look for CNS involvement. So sometimes they will have leukemic cells already in the CNS, and sometimes it hasn't invaded the CNS yet. So that's what they're looking for here. Then they do a bone marrow aspirate or biopsy to confirm the diagnosis, and then also to stage it. So you'll hear that it's like stage 3 or stage 2, something like that. Often, if it's stage 2 or above, they might show metastases to other parts of the body, and that can be harder to treat. All right, so right here is a bone marrow aspirate. They usually go out of the iliac crest. Extremely painful, so make sure that your kids or your adults, like even my husband is not a wimp, and he was holding on to the front of that table, like laying on his stomach, and this little tiny MA was like, you can hold my hand if you want. He's like, I'm pretty sure I'd break it. And he was like holding on to the table because they just said, hang on, like they didn't give it, this is gonna hurt for a minute. I think she even said pinch. And I was like, oh my God. And so I was sitting there, I was like, do you think you ought to give him some pain medicine first? Oh, this is really fast. I'm like, I know, but it's really painful too. So sometimes I think as healthcare providers, we should have to have some of these tests just so that we have a little more compassion, right? I have plenty of compassion. I'm plenty of compassion all my own. What's that?
I had to get tasered for work.
Oh, yeah. Oh, my brother-in-law's a police officer, and they had to too. Yeah, and it was, anyway, so make sure that they have good pain medicine. Even if it's an IM injection, if you're in a clinic or what. Nope. Just cleaned it off really good and said, hang on. Yeah. And I asked him, and he just told me, he's like, just be quiet. So I was like, I think you need some pain medicine or something. It's pretty fast. And he's like, just be quiet.
Oh, he told you to be quiet.
Yeah, oh yeah.
I was like,
Which is funny because he doesn't tell me to do anything, like ever. And so he was like, just be quiet. I was like, whoa, that's weird. Yeah, I'm just gonna sit here then. Because that was way out of character. Way out of character for him. All right, so lumbar puncture, they'll go right here. You can see the spinal needle that goes in right here in the space. And it will drain out just a little bit of CSF. It should be clear. Even if it's a very, very light straw, almost like urine that has a massive amount of water in it. It just barely has that straw color to it. As long as it's still clear. Okay, then that's okay. That's healthy CSF. If they have meningitis or something like we talked about a long time ago, beginning of the semester, it feels like eons ago, it can be kind of milky and kind of purulent looking. And you can see sometimes the sediment or the cells that are in there, it's not clear. So chemotherapy can be given. They can give it PO, IV, intrathecal. The IV is usually through a central line. Not just through a peripheral, it's caustic. And if it were to infiltrate into tissue, it would literally probably eat the tissue away. And little veins don't have enough circulation to really circulate it through very fast before it would literally burn through those little veins. So they usually will put them in a big central line, and I'll show you a couple of different ones. Intrathecal is right into the spinal fluid. Everyone has two treatments that they do prophylactically, basically, into the CSF. And then anyone who already has cancer cells in the CSF will have more treatments. as time goes on. Okay, so there's 3 phases of treatment: induction, consolidation, intensification, and maintenance. And with the induction, we think remission, they're done, right? Remission actually just means there aren't cancer cells present in the bloodstream right there from the bone marrow. And so 95% of them after 1 month, they hit them with usually a combination of medications because they don't want it to mutate and come back. And so usually they'll have 3 or 4 different medications that they have. So right off the bat, they might have 2 or 3, and then when they get in here in the consolidation piece, then they might add 1 or 2 more. With the remission, with the induction, they go into remission and they do the intrathecal treatment. Then they come here and it's post-remission. So we want to make sure that we don't have leukemic cells right now. And then we ramp it up. Okay, so then they add other medications. It's more intense therapy. And with this beginning part, with the going into remission, they do it in the hospital because it knocks out their cell counts. And so they're very low on their platelets. They're very low on they're already low on their white blood cells that can fight infection. And so now they are really kind of opened up for opportunistic infections that they can get very easily and not be able to fight off. And this will prevent regrowth and resistance when they have multiple different medications. And then with maintenance, they'll maintain their remission, and this is where it takes a long time. They can go through treatment 2 to 3 years. Sometimes they will, so how that ebbs and flows is they'll come in for IV treatment every so many weeks or months. Usually it's like 6 to 8 weeks or so, and they'll come in for a few days of IV medication. And then they'll be back out of the hospital. But what happens is it tanks all their counts, all their white blood cells, platelets, red blood cells, everything. It just wipes it out. And then they can't fight infections well. So usually they'll have to wait till that white count recovers just a little bit before they let them go home. Because then you let them out in the community with no ability to fight an infection. And they're going to end up right back because they're very neutropenic. And that just means low cell counts across the board. Anyway, and then they'll often they'll give them medications. Actually, I have that on the treatment piece. Medications that will help boost their cell counts. The CNS preventative therapy just prevents invasion of the CNS, and that's where they do like the 2 treatments to kind of help boost that so that they don't have invasion of the CNS with the leukemic cells. Isn't she cute? So cute. All right. If they relapse and they go back through reinduction, they can go through a bone marrow transplant. So when they go through the reinduction, then they'll end up going back through a bone marrow transplant. So, and then they have to have, so they can have a donor match for their bone marrow transplant, or they can have an autologous transplant. And this is where they, once they're in remission, so they go through reinduction. Once they're in remission, then they will collect the bone marrow. And then they go through high intensity chemotherapy and basically wipe out like every cell. They have no counts. You have to be so ginger, like porcelain, those little dolls, because if you move them up in bed, just a little bit of shearing on the sheet, like you drag a heel or something like that, and they can bruise so bad and end up with a big hematoma. So you literally have to just almost cradle them and lift them up in bed. And so you need 2 or 3 people, and that's why they got rid of a lot of draw sheets, because people would slide them up, but you might have it too low on their back, and so you're dragging a shoulder, or it just goes to here, and so it drags their legs. And so they told us that primaries was going away from draw sheets. I don't know when or how that's happened. Those of you that may have already gone to primaries might know better. But what we would do when I was in float pool, I'd go to the immune compromised unit, and we would put a draw sheet on the whole bed so that we could grab one person on each corner and just pick them up like a hammock and just set them at the top of the bed. And you weren't dragging their feet or their shoulders or anything like that. And And so they stay in the hospital during this whole process because they don't have any white blood cells. Usually they just knock them all out. Then they will harvest the stem cells. So they will have collected them. Now they'll harvest them and put them back in. They'll re-inject them. Well, like inject, like IV. They'll put them in an IV. And then they'll give them more chemo, they harvest the stem cells. They pull them out. They give them high intensity chemo. They pull them out. Then they give them more chemo while they don't have those stem cells. And that's where they go to zero. They try to take them to zero. And then they return the stem cells in hopes that the healthy stem cells will take over. I know, it's quite a process.
It almost sounds worse to have relapse than it is to just originally have cancer.
Well, yes. And if they've relapsed once, they're at higher risk of relapsing again. And the older they are when they relapse, the less likely they are to be able to make it all the way back through this process. So if they had it when they were very young and they make it and they're all of a sudden 19, 20 and they relapse, that's considered pretty old for this cancer. And so when they're older like that, in their late teens or 20s or whatever, and they relapse, then chances are the prognosis is poorer than it is when they're young and they go through it the first time.
Oh, goody.
I know, especially for boys. Sorry about it, guys. They treat them longer, usually several months longer. So like the 2 to 3 years back here, the 2 to 3 years, often they'll add like 6 months for boys because they are higher chances of relapsing. Okay, so this is called a PICC. PICC, it's peripherally inserted central catheter. So it goes in your antecubital and it goes all the way up into the right atrium. You've got major blood flow through here. And so they can give these caustic medications because every pump of that heart just washes that away, washes it right through the system. And so then you don't have it down in these small blood vessels. They'll usually have 2 lumens, sometimes more. And the 2 lumens sometimes will go into one port, which is, to me, counterintuitive. I don't know why we have 2 lumens if we're going to do that. But often for these guys, they'll have 2 lumens that stay all the way through. So you can actually run 2 different medications or 2 set of fluids and chemo at the same time or something like that. Then they have an insertion set up here through the subclavian where they can do, it's like let's just call this subclavian, but it's a central line that goes through there and it ends up in the right atrium also. Most of the time they do a port, and a port fits, they sew it into the muscle. So they just make a little opening like they did with the pacemaker, and they stick it underneath there and they sew it to the muscle. And then they just give them a little set of stitches, sew it back up. Then this is a Huber needle, and it angles like this. I don't know if they can see. And they basically just go straight into that port. So you just pop it right into that little port piece right there. And it's self-sealing, has thousands of accesses that can go through there while it's still self-sealing. It's under the skin, so it's less risk for infection, right? Because the other ones have an opening. This, as soon as they put that Huber needle in there, then they put a central line dressing over it, and that's a sterile dressing change. And so then as soon as they're done with their treatment, they can pull that out. And it's very nice because then there's nothing there. But it's interesting to me, the things that like little kids will know the names of things, or they'll know to tell these nurses when they're accessing that they should have a mask on. And when they're doing central line dressing changes and stuff, because that access to the skin should always have a mask on, and they should have a mask on too. And so they'll say sometimes, we're going to change your dressing, and they'll be like, I need a mask. And they'll just tell them, I need a mask, or you need a mask. They're very forthcoming with that. What was I going to say? There was something else. They also, this is so interesting to me, they get so nauseous with the chemotherapy that it starts to be preemptive. Sometimes they know they're going to get their chemo and they start to get nauseous. because they know that they're going to be sick. Like their little brain already goes there. And it started, and I didn't ever I hadn't made that connection real great because I only floated to that unit a number of times. But my husband started to get sick with the smell of alcohol because they would clean off the port and then they would access it and then he would get his chemotherapy and then he'd get sick. And so the smell of alcohol still makes him really nauseous. Is that funny? Yeah.
We, just after it was, the 17-year-old come in and we went in to we can access report and just like immediately after we saw that, just like threw up.
Yeah, it's pretty crazy. Your little brain already knows what's coming. Yeah.
Did they not give, I mean, maybe that's not how it works, but like,
Yeah, and preemptively. So like with Tyler's, they would clean it off, they would access it, and they would give him Emend, which is a really long acting one. And then they would wait like 20, 25 minutes or so before they would start his infusion. So it was on board and working, but he knew it was like his brain knew he was going to get nauseous. But the Emend lasted a long time. You could tell when it would wear off. So I was always trying to get him to start on his Reglan and Compazine and Zofran and stuff before the Emend was going to wear off. But he would never. He's like, I feel fine. But you don't want to wait till you're puking to take it. He's like, but I feel fine. Well, okay. Yeah.
I told a couple of people this, but when I was floating to that unit, we had a 2-year-old who had cancer, and they were waiting until his pH levels were in a certain range, and they can something with the timing, they can only wait so long before they have to wait until the next day to start it and do it all over again.
Yeah.
And so it was within the last 30 minutes of his time frame that his pH levels were correct for them to start this.
Mm-hmm.
And so they started it, and they didn't have enough time to give him the anti-nausea meds prophylactically. They were just we have to start this right now. And so I think I changed that kid's bed 11 times that night because he was just constantly throwing up, and he threw up his NG, and he it got to the point where you walk into the room and he just started screaming, "Ow, ow, ow!"
Mm-hmm.
It's so sad.
I think it's methotrexate that they have to do that with.
Yeah.
Yeah, that's poor nursing care in my view. If we're waiting on a pH to any minute come into line to be able to give chemotherapy, then we need to be ready. We need to be prepping that kid with anti-nausea medication on the off chance that any minute we're going to be able to give that. Does that make sense?
Yeah, and I think it was hard because that was just when I got there on shift, and so I think it was a shift change thing.
Oh yeah, and
they
that
just didn't
sometimes things get lost.
But it was so sad, and we were in there so much just because he was constantly throwing up on his bed.
Oh.
Yeah, I changed his bed a lot.
Oh my gosh, and that's so hard to see. It's
Yeah.
hard to see an adult throw up, but it's really hard to see a little kid throw up.
Yeah, he's 2.
So then it comes out their nose and their mouth because they
Yeah.
can't manage it well. It just comes out everywhere. Oh, bless his heart. So yeah, that's the nice thing about having a port is because then you can de-access it.
I might get this set up before.
Okay, infection prevention. Dun dun dun. Alrighty, let's bring up yours here. Okay, I think we're good. So this goes forward, and that goes backwards if you need to toggle.
Okay, so prevention of infection in patients with leukemia. So what is leukemia? We kind of already went over this. It's cancer of the early blood forming cells. Most often white blood cells, but some start with other blood cell types. And then they categorize it based on growing rates, and if it starts in myeloid cells or lymphoid cells. Fun fact, approximately every 3 minutes, someone in the United States is diagnosed with a blood cancer.
Wow. I didn't realize it was that frequent. Wow.
Yeah, and then also September is Blood Cancer Awareness Month. So there's that. So yeah, so leukemia in adults is most common with the chronic leukemia. So your chronic lymphocytic leukemia starts in the lymphocytes. That's about 1/3 of all leukemias. Chronic myeloid leukemia, also known as the chronic myelogenous leukemia, starts in the blood-forming cells of the bone marrow. That's 10% of leukemias. And then chronic myelomonocytic leukemia. And then the leukemia in children is your acute leukemias, your lymphocytic, and your myeloid. Leukemia is the most common cancer in children and teens, accounting for almost 1 out of 3 cancers. Chronic leukemias are rare in children. So with your signs and symptoms of an infection,
Sorry, I thought
it's okay.
I wasn't stealing your thunder.
No, you're good. It was just kind of like I wasn't sure if you wanted me to cover like what is leukemia, so I just kind of like put it in.
Yeah.
I'm glad I didn't go into that so much, so I can do it a little better. But your signs and symptoms of infection. Your risk of infection is obviously a lot higher when you are going through chemotherapy. So if you get, your temperature, chills, persistent cough, tenderness, sore throat, painful urination, and frequent diarrhea. So when you have the chemotherapy, your body doesn't produce enough white blood cells. That means that bacteria, viruses, and fungi in the environment, in your nose, mouth, or colon, and on your skin can invade your body without being destroyed by your white cells. So that's what causes your infection. Chemotherapy can also damage the lining of your mouth and intestines, making it easier for bacteria to enter your blood. So infection precautions made by your healthcare team. So antibiotics can be given to prevent or treat infection. Transfusions, so they aren't generally used for patients who have a low neutrophil count, but it may be an option if you have a high fever, an infection that's unresponsive to the antibiotics, blood fungal infections, or if you're in septic shock. You can also give growth factors. So your growth factors stimulate your bone marrow to make new white cells. The most frequently used ones are GCSF, so that's granulocyte colony stimulating factor, and GMCSF, which is granulocyte macrophage colony stimulating factor. And children undergoing chemotherapy don't get the growth factors very often. Washing your hands, obviously using gloves, proper PPE, and then port catheter cleaning. So you're gonna want to clean that port pretty meticulously so that you're not a good site for bacteria. Infection prevention is made by you, whether you're the caregiver helping the patient or the patient yourself. Using good hand hygiene, washing your hands often. Discuss infection avoidance with your healthcare team, asking like tips and tricks. You're going to want to avoid crowds or individuals with contagious diseases. So during flu season, you're going to want to make sure that you avoid those large crowds. Anyone that has any symptoms, stay away from them. You're going to want to check with your doctor about getting vaccinations. You should find out whether you should avoid people who've recently been immunized with live weakened forms of organisms or viruses that cause a disease, such as measles, and how long you should stay away. Don't cut your fingernails or your toenails. Avoid cuts or nicks when using scissors, needles, and knives. Use an electric shaver instead of a razor to prevent cuts. And you're going to want to use your soft toothbrushes that won't hurt your gums. You're also going to not want to squeeze the scratch blemishes so don't pop your pimples. If you're going to wash your cuts if you get a cut, you're going to want to wash it right away with warm water, soap, and then use an antiseptic. You're going to want to take a warm bath, shower, or sun bath every day. You're not going to want to rub your skin. It's kind of the same with the hemophilia. You're just going to want to be really careful not to have any way for infection to enter your skin. So pat yourself dry, don't rub super hard and give yourself an abrasion. If your skin becomes cracked or dry, you're going to want to use lotion and oils to help kill the skin. You're gonna want to wear protective gloves when gardening or cleaning up after animals, young children, or others. And then avoid uncooked fruits and vegetables if you have a persistent low white cell count. You can ask your healthcare team for diet and nutrition advice. That'd be a good time to get like a diet and nutrition involved. So for the learning activities, you just finished teaching your patient receiving chemotherapy for their leukemia about how to prevent feeding infections. I ask you if they'll be able to attend their family party that is coming up soon. What infection prevention tips would you suggest that would be wise for them not to go?
Maybe on people.
Yeah.
Possibly uncooked. I thought family, like, they're gonna have you, they're gonna have you for people to, more of a contract with people.
You could fall playing.
People aren't gonna be washing their hands all the time.
Yeah, so I just had live vaccinations, so if you have any family members that got maybe like their MMR recently, you're gonna wanna avoid them. Your raw fruits and veggies, and then avoiding crowds, avoiding people that are ill, and people that may be asymptomatic with COVID. So yeah.
Yeah. And you know, another food one that might be at your barbecue or whatever, is that the food is out over 2 hours.
Oh yeah.
And that's one thing that they say that avoid food that's been sitting out for over 2 hours. Good job. Thank you. I love how you guys clap. All right. The Wiggles? Isn't that like a group of guys?
Yeah.
It's a show.
Emma.
Is there a girl? I don't know. I just know that they sing.
Fruit salad.
I think my kids were just enough older that we sort of missed that.
Yeah, I see the Wiggles live.
Oh, that's nice.
No, it was like more guys.
Oh yeah, and then they got a girl. Okay, let's see here. I got the clap. Oh God. A couple other things that we had a student get this presentation one time that was worked at Huntsman, and they said no reptiles, like as family pets, because reptiles have salmonella on their skin. So even if you wash hands well, it's still there and it's around, and so they really shouldn't have reptiles in their household. If they drink, need to have covered drinks, like if they're drinking their water bottles or whatever. But it's actually almost better to use the disposable, like 16-ounce ones, or to wash these like every day. You know how some people just use the same one all the time? My boys, I'm like, put that in the dishwasher. They're like, oh, it's fine. I'm not sick. I'm like, well, you're probably gonna be if you don't put that in the dishwasher. And so also, like you said, that they need to bathe daily. Sometimes teenagers aren't great about that, or little kids or whatever, but they do need to bathe daily and use really gentle soaps and stuff like that. I think that was the only thing that he had said. Oh, and then report a temp that's greater than 100.4 for an hour. And then, because then you know that they probably have fever with their neutropenia, their counts are low, and now they're going to have to come into the hospital and get worked up and get some blood cultures and stuff done. So that was it. Sometimes I have to add lots of things, so I think that was really great. Okay, so preventing infection. So here's our nursing interventions. We need to prevent infection. Protective isolation. So she talked a lot about preventing infection, and the only thing that here would be protective isolation. So sometimes, a lot of times we put on gown, gloves, mask, whatever to protect us and to protect the other patients we have from this person who's infectious. But sometimes their counts are so low that to keep them safe, we will put on gown, gloves, and masks to go into their room to risk bringing something to them. Okay, it's called protective isolation or reverse precautions is sometimes how you'll hear it too. That you will see more like bone marrow transplant sometimes than just somebody who has a little bit of a low count with their current chemo. Medications, dosing beforehand, particularly your antiemetics. If they're throwing up and now you're giving them antiemetics, you are behind the 8 ball, and it's going to take a while to catch up. Neupogen and Neulasta are some of the medications that will help increase the white blood cells. So how she said that they will give in much more depth, you said, than I will. But these are 2 medications. Neupogen is one that is given a little more frequently, and Neulasta is usually like every 2 weeks. So they go through this cycle where their counts are here, they have their chemo, and then their counts do this, and then they get their growth factor, and then it starts to recover. And so they will start to do this a little bit, especially if they have treatment like every 2 weeks, or every 3 weeks on the off week, then they'll give them like Neulasta. Or 5 days after treatment, they'll give them some Neupogen, and then again 5 days later or something like that. And it's the growth factor. It recovers those white blood cells a little bit faster. Nausea and vomiting, dosing beforehand. I can't tell you enough about that. Don't wait, especially if you know you're going to give chemo and you're waiting for PH to come in line or something like that. Make sure that you're treating them as if you are going to give chemo. Does that make sense? Zofran, most of us are very familiar with Zofran on Danzatron. Benadryl and Ativan. When I first floated to ICS, the immune compromised unit, they said on this little kid's list, it was scheduled Benadryl and Ativan. And I thought, that's weird. Nobody said they had an anxiety problem, and nobody said they were itching, and they were like, I'm thinking of all the things that these are used for. Plus, together, they're gonna make them super sleepy. And so I was like, okay, I gotta figure this out. So I went to the charge nurse, and she said, oh, those 2 together are a really great antiemetic. I was like, who figured that out? That's so cool. But anyway, they get used to it. They get sleepy. You give it to them, they take a nap. But it really works really well to kids who've had so much Zofran that their body's just like, yeah, I'm not having it. Emend is one that works longer, but it will not. It's pretty expensive. And so they don't, insurances won't often pay for it for just your regular post-operative nausea and vomiting. And it lasts a lot longer, like 10 or 12 hours. So they can go through treatment and they can have this. But as it starts wearing off, you need to have other things that you're putting on board. Yeah.
Most of I've seen these little things, called queasies, I could be wrong. What's the story with those?
I don't know much about them. I know the name. Does anybody know? They're called queasies. Does anybody in the chat know?
Put them here so they can smell it.
Yeah, so they can smell it. Well, I do know that lavender and peppermint and things like that, some of those essential oils will help with nausea. The funny thing is that alcohol swabs generally help with nausea, which is so funny because it will make my husband vomit. Smelling salts sometimes too can help some people, but I do know essential oils, some of those, and maybe that's what's in those queasies. Is anybody saying anything in the chat about them? Ashley Hyatt said, didn't someone say that lemon has helped nausea at our clinical last week? Oh, yeah, that's right. She's in my group. Lemon helps somebody with nausea. And I do know peppermint can, and some people have said lavender can too. So, are you reaching over your plexiglass? No, I didn't. Don't do it. Say no, Kim. All right, and then IV fluids, they get really dehydrated.
Yeah, we also have Claritin on our downloaded PowerPoint under med.
Oh, yeah. I added that later. It was something that a student told me, because remember I said this was old? A student told me that Claritin helps with nausea too. And I think she had worked on ICS, or she had floated there or worked at Huntsman or something, and told me that was a good one. So yeah, that's not a mistake that that's there. Provide appropriate pain scales and medications. They can be in a lot of pain. Especially if it's metastasized to the bone. Yeah.
So a couple of things on the chat. You guys said what Ashley said, but Taylor says sucking on mints help too, especially when accessing the port.
Sucking on mints, okay.
She also says keratin helps with bone pain after receiving growth factors.
Oh, how about that? Claritin helps with the bone pain too. Okay. I think that's where it falls over here. Doesn't it under analgesics, the Claritin? Just under medications. It may, because the analgesic seem to remember that too.
And then Queasy's is drug-free, all-natural product consisting of a unique blend of pure essential oils.
Oh, okay.
It helps with surgery, anesthesia. It's also beneficial for soothing motion sickness, morning sickness, and chemotherapy related.
Oh, perfect. That is great. Was that a text to you or is that a chat on the chat?
The old Google.
Oh, okay.
I Googled it.
Okay. So the Queasy's is a mix of essential oils that can help with nausea, motion sickness, morning sickness, and the nausea related to chemotherapy. Yeah. Thank you. That's awesome. All right. A PCA, morphine or Dilaudid, sometimes they're, especially if they've been there for a long time and they've had a lot of growth factor to try and recover those counts. Maybe they've had metastases to the bone and they're having a lot of bone pain. They will end up needing quite a bit of medication. And then other medications for non-pharmacological interventions. Don't forget stool softeners. Why are stool softeners a big deal? Straining, okay, because what is really low? Platelets. We don't want them to start bleeding, right?
Yeah.
We don't want hemorrhoids. We can't give enemas or suppositories or things like that because their platelets are really low. So we need to have things be really smooth and really slick. Just be able to not strain, not have any issues. And a lot of them are getting narcotics. So we want to make sure that they've got those stool softeners on board. Then there's mucositis. Their poor little mouths, all mucous membranes can be affected, so sometimes their eyes, but mostly their mouths and clear down their throats sometimes will get these open sores. It's horrible and it's very painful, and so even if they're not nauseous, they still won't eat and drink because it hurts so bad. So they have magic mouthwash, and I have never met a pharmacist that did not know what magic mouthwash was. And most of the time it's Benadryl and lidocaine and Mylanta. Sometimes they'll put prednisone in it and nystatin if they have a yeast infection. So sometimes they'll get thrush in their mouth and they'll end up having nystatin in there. But with the lidocaine and the Mylanta, it kind of kills the acid, numbs things up.
Looks like a GI cup.
Yeah, a little bit. So usually they'll swish and spit or they'll gargle so they can get it in their throat. They do have to be careful with the amount of lidocaine in it if they're going to be swallowing it because then it numbs everything and sometimes it can interfere with their gag reflex. And so if they're really little and they don't know how to gargle or swish or whatever, they can get those pink swabs and they can just paint their mouth. That works really good too.
Chantel, another thing along that is like on ICS now, they like the kids to get up and do mouth care 3 times a day. Because if they're brushing their teeth with a soft toothbrush, then that's preventing any like bacteria from like building up in their mouths to prevent infection getting through
the source. Oh, that's good. So if you guys didn't hear that online, they're suggesting that they do mouth care 3 times a day. Is that what you said, Kylie?
Yeah.
To help keep the bacteria down in their mouth so that if they do get those sores, then the risk of bacteria getting into those sores isn't as high. I keep trying to remember to repeat what you guys say. Okay. All right. Prevention of bleeding and injury, thrombocytopenia. So the soft toothbrush, check for signs of bleeding. Promote energy, conservation, and rest. So the minute they feel good and they want to be up, they want to do things, they want to go, because they're kids and they haven't been feeling good. And so you really need to kind of pace them a little bit when they're feeling good. Emotionally supportive care, so relieve their anxiety. Sometimes you can't say you're not going to die. Does that make sense? Because that really is a big reality for them, and that really causes a lot of anxiety for them and for their families. And so using your antiemetic and pain medications are going to help relieve their anxiety, but then letting them talk about their feelings. There is actually a pediatric oncology psychologist. Is that a narrow field or what? And they're amazing with what they do. And so you can always get them to get social work to give them a referral. Music therapy, massage therapy, aromatherapy, and then I put acupuncture. On my newer one, I had changed that to acupressure. But looking at this, I'm like, oh yeah, that was back before I changed it. So don't do acupuncture. These, they're at a risk for infection and bleeding, and don't be sticking needles in them. Plus, they won't like you anyway. So acupressure sometimes, if they're a little bit older, and they're more open to some of those other kinds of care.
So acupressure?
Acupressure.
Should change it to?
Yes,
Okay.
not acupuncture.
Got it.
All right, emotionally supportive care, so social isolation, and additional quality nurse time. So these guys, families can't stay 24/7 for months on end, right? Somebody has to make money. Somebody has to take care of the other family members. Somebody has to work so that they have insurance for all of this. And so a lot of times these kids are alone for sometimes for a day here and there, sometimes for many, sometimes for hours. So you want to make sure that you try and give them the most quality time that you can when you're in there. And then have your volunteers. Like if you have kids crew or whatever, bring them a toy. Theirs can't be ones that other people, so like give them coloring books and crayons, I guess. What I'm saying is they can't have toys that are on their cart that have gone around the hospital that have probably been cleaned with cleaners and stuff like that, but they've been on lots of units and stuff. You have to really watch their counts before you just go taking things in their rooms. Relieve their anxiety of the child and the caregiver. So hook them up with their child life specialist, social workers, and give the parents some time too. Sometimes they have been there for a long time. They need a minute to, sometimes they almost need permission to go for a walk. Promote normal growth and development. So that's kind of where your little growth and development piece comes in when you do your primaries rotation. Is you have these kids, sometimes they're in the hospital for a long time and we're really impacting that. They can have physical therapy, occupational therapy, and speech therapy. Promote a positive body image. So a lot of them lose their hair, alopecia. So wigs, caps, beanies, scarves, all kinds of things. Make it kind of fun for them. A lot of the units will have like a basket of things that are donated, like people who crochet really well and stuff like that will bring and donate, drop off baskets of things so that they have beanies and stuff like that. And then promote family coping. Make sure that that social worker knows their needs and can come and visit with them, and then get them hooked up with support groups. The nice thing about so many things being online right now is that they have a lot of resources that they didn't always have before because people have tried to push everything online. And so they can be hooked up with support groups and stuff where they don't necessarily have to be in person. With their fatigue, the causes, cancer treatment, low blood counts, poor nutrition, fevers and pain, this depression and worry. When someone has depression or they're worrying a lot, it really can take its toll just on their energy level. And so that in and of itself can be pretty daunting. Trying to do too much when they finally feel good, and interrupted sleep. Because do we let them sleep very long usually? No, we're in and out, in and out. So really try to cluster your cares with these guys too and stay out when you can so that they can rest. So your management, encourage daily physical activities, even if it's just getting up and walking to the bathroom, as opposed to putting them on a bedpan, right? Because they're just like, I just want to use the bedpan. Come and walk with me just to the bathroom. And it keeps them just a little stronger. And it gets them out of bed, gets some of that pressure off their backside. Healthy foods and snacks every couple of hours. So that's why it's super important that you stay on top of their nausea. Talk to a dietitian, a regular bedtime, good pain control, and uninterrupted rest. So clustering our cares. All right, thrombocytopenia. So this is like when their counts are really low for their platelets. Handle the patient gently, manual blood pressure. So most of this, I'm trying to think if there was anything that wasn't covered in her bleeding thing. No. And the unnecessary needle sticks, really have to evaluate when their platelets are low, how much they need an injection. Okay. And then patient and family education basics, infection prevention, bleeding and injury prevention, talk to them about pain, energy conservation, anxiety reduction, and this is patient and family. Okay, so make sure you don't leave them out. Normal growth and development, their body image, a lot of them have NG tubes because they need to have that extra nutrition. They're missing their hair, and it's not just their hair that falls out, their eyelashes fall out, the hair on their arms, which I guess for some people that might be a good thing if they felt like they had too much hair on their arms, but and then sometimes it doesn't grow back the same, so when it starts to grow back, maybe it's a little bit different color, or maybe they had really curly, lush hair before, and now it's thin and it's straight. So really kind of capitalize on the good things about their body image. And then family coping. This was all of the family education things that we talked about for infection prevention, but sometimes I don't have a presentation for it. So I always make sure that I put it there at the end. All right, so I like this definition of palliative care. It's comprehensive and holistic. It's an approach to the care of children with serious illnesses. It supports children and families by easing physical symptoms, as well as helping with the emotional, social, and spiritual aspects of living with a serious illness. We have a student who has now gone on to be a palliative care nurse practitioner. And this was one I told him that I had, and he was like, that is really a very inclusive piece of palliative care. And hospice is an arm of palliative care. So they're not the same thing. They do have very, very similar resources. But for palliative care, this isn't the one where they only have 3 months to live. They only have, palliative care is more encompassing all of that comfort care. Okay. Hospice is generally where we're kind of coming down that home stretch. Okay. Home health? Yeah, so it can be palliative care. You can put them on palliative care for home health and get them those resources. Sometimes insurances pay a little better if you put them on these services, as opposed to just trying to get generalized home care. Does that make sense? Physicians, nurses, social workers, chaplains, and others need to be on your team. So the chaplain, maybe they are spiritual, but they're non-denominational religious wise. And so some of the chaplains in the hospital are non-denominational, and they can treat, or they can kind of help them with their spirituality in general. Okay. Last, some therapeutic communication. This is from a conference I went to at Primary Children's, and they had one of the cancer physicians, and he said one of his favorite phrases is, I wish and I worry. So you have parents that are down to, we have gone through remission a couple of times and have relapses, bone marrow transplants, tried a drug that is off-label that we're trying to do trials on, and now we've relapsed again. And they are like, what do we try next? And you have this poor little body that's in the bed that's been through all of this probably for years. And he said he will go to them and say, I wish there was more that we could do, or I wish there was another medication, but I worry that we've exhausted our resources. And then it communicates that I'm on the same page with you. Does that make sense? I wish there was also this, but I worry that there's not. And then he said, we're hoping for a miracle. Make sure you know what they're hoping for, what their miracle is. And I thought that was interesting, because then it took me back to a time when I remembered this lady in the ICU, and her son had been in a terrible accident and was dying. And he had been on life support and had ARDS, so respiratory was just tanking. And they had him on vasopressors, and they had him on all kinds of things, but he was circling the drain. And we knew that this was not going to be a good outcome. And they were trying to talk to her, and she kept saying, we're hoping for a miracle. And as a team, we were like, oh, what isn't she understanding? Like, how many more ways can we say this? Because this is not like this, we're coming down to hours. And one of the physicians said to her, what does your miracle look like? And she said, he hasn't seen his dad in years, and his dad's on a plane right now, and he's coming, sorry, and he's coming here, and I just want him to be able to say goodbye. And we were like, oh, we can do that. We can keep him alive for a few hours, right? Till dad gets here to be able to say goodbye. And so asking them, instead of just saying, oh, she's crazy, she thinks there's a miracle, you know, and we don't understand and we don't know what that is, ask them what their miracle looks like. And then you as the nurse need to have the right to grieve. Yeah.
Did he make it?
Yes.
Oh, good.
Yes, he did. Sorry, I'm the biggest boob in the world, much to my whole family's dismay.
I had a similar patient came in with seizures, and this kid had drowned in the bathtub, and parents were on vacation 4 hours away.
Oh, yeah.
So they had to wait. They were trying to keep this patient alive until parents got there. And it was the saddest.
Yeah, yeah, and that is so hard when they've had an injury. Sometimes they would be life flighted into primaries, and they'd be life flighted in from Idaho, and parents are in the car driving from Idaho, and they're in the ICU, and you don't know if you're going to lose them, and parents are on the road. Yeah, so just be, I guess, really aware of some of those things that we need to try and stretch to the limits, I guess, to help these guys. And then you need to have time to grieve. You will have a few patients that really get close to home, a few that are very, very tender to you, and you need to give yourself time and permission to be sad and to be sorry for their loss. For these families, you know, and I think of one in particular that was a gal that had an astrocytoma in her brain. That is terribly hard to treat because it has like all these finger-like projections. It goes out through the brain tissue. And after it was about 18 to 20 months of brain resections and chemotherapy, nausea and vomiting, watching this robust little cheerleader sort of waste away, lose her hair and have big incisions and still always have that attitude that you always hear about, you know, these people that are like, it's okay. There are people that are worse than me. You know, there are people that are worse off. And she just was so genuine and so fun to be around. It was fun to take care of her as much as it was hard. And I was her primary nurse on the night shift for 18 months. And when she went home on hospice, that was really hard. And her mom let us know when she passed away. And I saw him in the store about 3 or 4 months later. It was about Christmas time. And her brother was struggling. And she said, but the thing that he remembers is the care that she got and how happy she was her to the end and how people took such good care of her. And that's, and then you have to say, I did the best I could for 12 hours and then leave it there and go home so that you can be present for your families. And then when you go back, you do the best you can for 12 hours and make it everything that it can be for them. And these are hard patients they wear on you. They really do. And the neurotrauma patients that are there for a long time with traumatic brain injuries really wear on you. So make sure you take good care of you too. All right. There's some clicker questions there, but I would rather do our quick little activity. Oh yeah, we can do it in like 10, 15 minutes because this is more fun. And I will post the clickers online. So you guys online, sorry about it. You don't get to play this game. But the clickers that are next on this presentation, I will post online. Okay. So you guys, I guess on Blue Button, peace out. Have a good day. I know. Well, I don't know how to help them. I don't know how to help them have a good time with this game. Okay, so we're going to turn up the lights here. All right, so usually I divide you guys into several teams, but I don't need teams of you guys running through here. So what we might do is just do 4 at a time. Okay, so I need 4 volunteers. There are prizes that are involved. Okay. Okay, Rain? Yes. Come on. All right. What is the one that's on the bug on the back? What does it say?
Infection prevention.
Infection prevention. Okay. Come on.
What is that for?
Come, Mark. All right. So listen to where these bugs are, and I'm gonna have all of you guys start right down here together. Okay. Then this is bleeding prevention. And then this one is clinical manifestations of leukemia. This one is clinical manifestations of anemia.
Oh.
This one is anemia prevention. And this one is, what is it? Clinical manifestations of hemophilia. So I'm going to move this chair out of the way. Okay. I know. Okay, so maybe should I turn this around so they can see you guys run? Okay, so I'm going to give you guys a clue. Okay, and then you have to, I don't want you to be able to see through the paper. What's that? Yeah. Okay, there you go. I'm going to give you a clue, and the first one to slap the bug that goes with, so whether it's like bleeding prevention or whatever it is, clinical manifestations of leukemia, first one there gets a point. Okay? You have to keep track of your own points. Okay, here's your first clue. Eat kicks.
Right. No, that's
Wait, no, it's anemia, but I was like, it's not prevention.
That's that one.
I have to look. Yes, it's anemia prevention. I was like, wait, one for Kim.
Then you win 1 point.
Good job, kid.
All right, here we go.
Oh my God.
Let's see. I need to get it out.
I was like, what are kicks?
It's the cereal that has iron in it.
First example that I
Get
kicked in the face. All right, ready?
right.
Factor replacement.
Oh, wait a minute.
Oh.
I know this one.
I know it's a hemophilia, but it's not. Oh, yeah. What? No. Replacement. It's a treatment.
What's on the back?
What's that thing? I can't see.
That's infection.
prevention.
Oh!
Can I just take 0 points?
Okay, so one for you. You're
I
down to
was
1
gonna
to
take
1.
this.
I'm just gonna take 0 points. Call it a day.
Okay, here we go. Abdominal pain.
I don't know. I should have. Tim got it. Bless! I should have thought of you. Leslie tried to even help me.
Hemoglobin less than 11.
Got it.
I was smacking this one the whole time.
It's right about eye level. Is that?
Oh!
You know I love you.
It's the only one I can see.
I have to get short jokes anytime I can because I am the shortest by far in the house.
Yeah,
And I do them all the time.
Yeah, Mark.
All right, here we go. Let's see. No reptiles. Oh, yeah. I'm not running. I'm not running. There you go.
That's the only one I knew.
Okay. So, let's see. So we're 2 and 2 and 1? Okay.
This is like, if you're not paying attention in class,
That's right.
right up to your
Ooh, Wake up. Wake up. Okay, here we go. Red meat.
Red meat. Red meat. Oh, I'm right here.
What is that one?
Anemia prevention.
Bam, there you go.
Let's
I'm
go.
like, I don't know. What's happening here?
Come on, Megan.
All
One
right.
and a half, dude.
Okay, here we go. No NSAIDs.
Oh, that's.
In your book, it will say, and I have this in my newer presentation, so I'm glad that came up. In your book, it will say that NSAIDs are often given for pain or whatever, but then it says, but not, it's kind of a secondary statement. I'll put it on Canvas because these guys have probably already logged off. Some of them are still there. Oh, so we need to tell them who's winning.
It is, I think.
No,
2 and 2.
2 and 2 and 2. Yeah. Okay. So the NSAIDs.
That's what I was thinking of doing.
NSAIDs in your book are a little vague, and it kind of leads you down the path that maybe they're okay, but best practice in the research says no NSAIDs when they have hemophilia. Okay. So that's something I watch pretty close and keep up to date. Okay. All right. Start out right here again. Ready? No reptiles. No reptiles.
Where did we go?
Oh, did we?
Yeah.
Okay. How about
Doesn't count again, dog.
unexplained weight loss? Oh.
That's 2.
We're on time.
So we're on 2? All right.
That is so not 2. She forgot. Dude, I knew it was that.
She ran for it.
No.
Okay, here's for all the marbles.
Oh man.
Scared. Okay. Rice.
Rice.
Wait, no.
That's not it.
Wait, that?
Anemia prevention.
Oh, wait.
Oh, wait.
4 things.
No?
Oh, like rest?
That's what it is.
Yeah.
Rest,
Rice,
ice,
rice.
yeah,
Rice.
compression.
Rice.
No,
Rice.
Bam. Good job. Thanks for playing. Jaden, have you ever been to my office? All right, you guys can come get a treat in my office. Okay. So you guys are all set. I will put that announcement about NSAIDs on there for anybody who may have logged off already.
I told them they're.
Okay. All right. There's 6 people left?
Only 6 people left.
Oh, only 6 people left. Okay. I probably should have followed them with my camera, right? All right. You guys are good to go. Let's see here. I need to stop sharing. Okay. Goodness. It's kind of crazy in here. I miss your faces. I'm glad you guys stuck with us. You should have seen the chaos that ensued. All right. I will put an announcement on Canvas about the NSAIDs for those that missed that. And then you guys have a good day. Debbie will be in here in 5 minutes. So take a 10-minute break while we switch media. Okay? 10-minute break, and then Debbie will be in here. She'll start a conference for a study group for the farm. I was like, for what? For farm.